All right, cardiac, part 1. Here's your objectives. Cardiac assessment. So you all know how to do a cardiac assessment. I'm not really going to go over that aspect of it. Patho review. You have your vena cava, the right atrium, the tricuspid, right ventricle, over the pulmonic, over to the lungs, pulmonary veins, left atrium, mitral valve, left ventricle, aortic, and then aorta. So assessment pieces. So cardiac family history is very, very important when it comes to assessing the patient's history. If a sibling or a direct aunt, uncle, or a parent or grandparent has had significant cardiac issues, we would be concerned for that when it comes to our patient here. Other things we're going to look at is nutrition. Remember, fluid volume overload patients are very typically cardiac patients. They're in either post-STEMI treatment and the STEMI didn't go well, or they're in congestive heart failure. Both left and right-sided can cause that. So some diagnostic tests we look at. Troponin. Anytime we think someone's having a STEMI, we're going to be checking troponin levels. We're going to be checking lipid levels if they have a history or they have a family history. Lactic acid, that's all about sepsis, which we're going to get into in part 2. BNP, that indicates the severity of the heart failure. Cardiac catheterization, which we'll talk a little bit more. Stress test. Stress test, treadmill type or chemically induced stress test. Very similar things. When it comes to the stress test, both physical or medication induced, we're going to ask about caffeine use. Caffeine use is contraindicated, and use of metformin, because the dye we give during the stress test is very hard on the kidneys. So if they're also on metformin, we want to be knowing. Doesn't mean we're not going to do the stress test, but we might want to do like a half a liter of fluid to wash them out beforehand or during. Some things we're going to ask when we're prepping them for a pharmacological stress echocardiogram. We are going to be having them on continuous pulse, so heart rate and blood pressure. They need to be NPO at least 6 hours beforehand. And we're going to use dobutamine, which is used the majority of the time for this particular echocardiogram stress. Heart failure. You guys have probably so sick of hearing about our heart failure, but it is the inability for the heart to pump effectively. So left side heart failure, it's all about the lungs, okay? They have a cough, they're dizzy, they have pallor, they have dyspnea. They're the individuals that when they try to lay down at night, they can't because all the fluid backs up into their lungs. Right side heart failure, that's what you see. That's the rings on their hands get tight. They can't get them on, they can't get them off. Their socks and their shoes become too tight. They have to go up in a size. There's your path of heart failure. Different types of cardiomyopathy. So there are different types, but we're not going to get into the specifics of the different types. Those are not a NCLEX objective here. They can be caused by hereditary. They can be caused by different types of infections. A lot of times individuals with cardiomyopathy will have to have some sort of treatment. Again, cardiomyopathy patients are going to be a fluid volume overload patient, so we're going to be watching for that aspect. Some of the cardiomyopathies can recover for themselves, but a lot of times we have to do medication or surgical intervention. So management. So it is very common for a cardiomyopathy patient or a heart failure patient to be on digoxin. So if somebody is on digoxin and Lasix because they're in fluid volume overload and their heart's not doing well, make sure we're watching that potassium level before we are administering, giving any of the meds really. Make sure the potassium level is well above normal. We're also, before we're going to give DIG, we're going to be assessing for GI issues and vision changes. So worsening or recurrent heart failure, this is when it calls for weighing, having the patient weigh themselves. If they've had a 1 to 2 pound increase overnight or a 3+ pound within a week, they need to contact their physician. We'd be worried about a flare-up or the medication not being as effective. They might have a decrease in exercise tolerance and look for that edema. So complications, there's a lot of complications. I know we talked about a bunch in MedSurg 1, but we're gonna bring them back up here in MedSurg 2. So edema and pulmonary edema. This is a very reality aspect that can happen because of all the fluid volume overload. They can go into cardiogenic shock. In part 2, we'll go over the shocks a little bit more. And then something called cardiac tamponade, where fluid accumulates in the pericardial sac. We do try to do different medications for that, but a lot of times we're going to do a pericardiocentesis or something called a window, where we literally go in and cut a small hole into the sac to get the fluid out. All right, so let's talk about chest pain. The #1 medication treatment for chest pain is nitroglycerin. So if it's going to be a sublingual, if it's going to be a drip, we are going to be asking how their chest pain is. When we're giving nitroglycerin, the goal is to get them to 0 pain level for chest pain. So if they're still a 2, 3, 4 on a scale of 10, we're still giving the nitroglycerin. Nitroglycerin should completely eradicate the chest pain, or we are not giving enough. Coronary artery disease. In CAD, there's not enough oxygen getting to the heart. There are different types of angina. Stable angina is typically when the patient gets some chest pain or chest tightness for 15 to 30 minutes and it resolves with a single dose of nitroglycerin under the tongue. Then it can get as serious as an acute MI. An acute MI is where they are having the ST elevations. They have a blockage and we need to do a code STEMI and go to the cath lab to fix that issue. Acute coronary syndrome, this is unstable angina. So what I was just talking about, the chest pain occurs and lasts for over 30 minutes. It's not relieved by nitro, and it causes severe limitation for any type of movement. So going into an acute MI, this is what we're talking when we call it a STEMI, a code STEMI, okay? You can have an N STEMI. N is no EKG changes, but the troponin continues to go up. Remember the troponin, normal troponin level is really low. So you can have someone having a heart blockage and they need a cardiac catheterization done, but there's no EKG changes. When we call a STEMI, there is an EKG change. Typically the ST elevations have increased and there's a troponin increase. This is a medical emergency, and we do have to get them to cath lab to save the heart. Sometimes when it's very severe, it can actually go to open heart surgery the same day. So assessment findings. When we're looking at assessment findings with acute MI or ACS, we're looking to see if the cardiac muscle isn't perfusing. Is it not getting enough oxygen, blood flow, or is it just poor? Very typical signs and symptoms. Males, you're going to have the chest pain, the jaw pain, the shoulder, the arms, the shortness of breath. Ladies, you're going to get the jaw pain, the fatigue, and the GI upset. So lab and diagnostic tests, we talked about the troponin levels, the CKMP and the myoglobin. Those are all going to be elevated, though troponin is typically the one we look at the most, and that's usually the serial labs that we're talking about. When we're talking about serial troponins, that means we're doing them every couple hours for usually 24 hours. We also can see 12-lead 12-lead EKG changes, especially that ST elevation. So interventions, typically outside of the nitroglycerin, which remember, if we're going to give nitro, we're giving enough nitro until the patient's pain level is at 0. During this time, we're also going to be watching for fluid volume overload. So watching the heart, we're watching the respiration rate, and we're watching the blood pressure. All right, now we're talking about going into the cath lab itself to put the stent in, open the artery. A lot of patients post-op cath lab will be started on Plavix. Now, some of the stents that we're using lately already have an embedded blood thinner in it, so they're actually not on any type of blood thinners long term. So let's talk about cardiac cath pre-op, okay? So 4 things we're going to be watching for and assessing for renal issues right before that cardiac cath happens, okay? We want to make sure the patient does not have an allergy to iodine. We're going to be giving IV fluids before the cath and during the cath to keep the body washed out, because those dyes we give during a cath are very hard on the kidneys. We're going to be watching the BUN and creatinine levels because of the kidney factor. And before, we're going to talk about immobilizing whatever extremity is used. So we want to make sure, especially if it's a leg, is that impeding any type of urine emptying. Post-cath, so patient's done with the cath and they are in the they are in recovery. We're going to be watching for any type of dysrhythmias. We're going to be watching for any type of potassium issue. And we're going to be watching the cath site, whether it be the arm or the femur. We're going to be watching the cath site for a hematoma or a growing hematoma. Remember, hematomas mean bleeding, and bleeding on a hematoma means there is internal bleeding. And post-op wise, when it comes to cardiac cath, we are watching the pulse below the pulse. So if your patient had a cardiac cath and it went in the brachial, we're watching the pedal. If your patient had a cardiac cath in the the femoral, we're watching the pedal pulse or the popliteal pulse. So whatever is lower than the site of the cath, that is the pulse we are most worried about. Biggest complications of post-MI, they can have a heart failure. So that's why it's so important to watch for signs, symptoms of fluid volume overload. Your vital signs are going to be your first indication that there's a problem. Cardiogenic shock. We are going to go through the shocks in part 2 more, okay? So we'll get those more into part 2. If the patient needs we call it a CABG, it's a coronary artery bypass graft. This is open heart surgery, we call it a CABG. Once your patient has completed the CABG, Make sure you are watching urine output, especially if they have a balloon pump still in. Balloon pump is our measurement tool for the body's output, and the secondary measurement tool for that is going to be urine output. So if they have a balloon pump in, we're going to be watching urine output. All right, you guys can look at the questions yourself, and I will be posting 2 shortly.